Hi everybody, and thank you for joining me in this new short video presentation regarding the ECG exercise number 16. I hope you will enjoy it and join me in my future video presentations. Thank you. Our patient is a 35-year-old man with frequent monomorphic PVCs with a PVC burden over 24,000 per day. Cardiac MRI showed no late gadolinium enhancement, but an ejection fraction of 35%, suggesting a tachycardia-induced cardiomyopathy as a possible diagnosis. So this is the baseline ECG of the patient. Typical ECG for a PVC from right ventricular outflow tract. We have left bundle branch block morphology pattern, inferior axis, RS transition later than V3, and RS transition in PVC is later than in sinus rhythm. So it is compatible with an origin from right ventricular outflow tract. In the next ECG, I would like to emphasize on two interesting findings. So the first finding is oscillating morphology. We see that there is a slight change in the morphology of the PVC. And these morphology change in RVOT PVC, from my experience, is a sign for an origin from pulmonary artery. And that was exactly the case. And in this patient, we ablated the PVC in the pulmonary artery. The second important thing is that all the PVCs in this patient are interpolated. Interpolated PVC is a risk factor for tachycardia-induced cardiomyopathy compared to the PVCs with a compensatory pause after the PVC. So, in conclusion, this ECG has two interesting findings. Number one, oscillating morphology in RVOT, which happens frequently in patients with PVC originating from the pulmonary artery. The second finding, the PVCs are interpolated, and the interpolated PVC is a risk factor for tachycardia-induced cardiomyopathy. Once again, thank you for joining me, and I hope to having you here in my future video presentations.